I think the advent of IVL has given us a real boost in considering how to treat calcification optimally. And instead of just doing enough, we can now really do a good job. The advantages of Shockwave when we're treating calcific disease are really in two groups. The first is the safety. I was an investigator in the Disrupt trials, and we saw the safety profile there, but also the ability to get an optimal stent result. So with Shockwave, you're getting a much better upfront preparation of the lesion, and that then allows you to deploy your stent optimally. Ultimately, what IVL has given us is it's given us the opportunity to treat some lesions which were almost untreatable. But perhaps more important, I think, is the ability to treat long segments of calcified disease safely, where we're not putting the patient at risk from extra devices and uncontrolled expansion of balloons and the risk of rupture. And I think that has allowed us to move into the really complex cases with an element of safety which we perhaps didn't have before. But with IVL, we can now pretty much do all our cases using the femoral approach. That makes it more familiar for us, it makes it safer for the patient, it improves the throughput in the lab. I believe it reduces the risk of stroke, and it's really been a huge step forward in my perspective. One of the interesting things is that using IVL in the iliacs really hasn't meant that we end up putting in stents. Safe dilatation of the iliac arteries with IVL has meant that we can access the descending aorta safely, and in our experience hasn't meant increasing number of stents ultimately at the conclusion of the procedure placed in the legs. But actually now with lithotripsy, we've really pretty much do all of our cases femorally, and that has great implications for safety and for throughput in the cath lab, in that we can move our cases through more quickly, and it's been a great step forward.